not certain how I should approach this dubious honor of talking to you after lunch. I first thought maybe the smart thing on my part to do would ask him to be turn down the lights. I could talk in a very monotone. We can ask you to close your eyes and begin to think about hearing the mountain stream. Turn the heat up in the room, and maybe I can sneak out of here. But NET tumors here. There we go. Since I'm kind of following a number of other people who have been talking about this, we may hit a few of these points, and I'll try to brush over them quickly. That was quickly. Basically, carcinoid was first described in the 1830s, and it's a thoracic disease. However, for the next 100 years, or majority of the 100 years, it really kind of sat quiescent. In the last 30 years, there's really been a much better recognition. There we go. A much better recognition of the fact that this is not a benign disease. That this needs to be approached as a malignancy, of which for many it's a low-grade malignancy, but it still is a malignancy, and for a few it becomes a higher grade or is a higher grade. And so with better testing, better pathology, we now really understand that there's a differentiation from the small cell and other glandular tumors of the chest. The tumors, as you have all heard, may produce the various different metabolites, and over time we can talk about that. However, the great majority of the thoracic disease, am I doing something there that, there we are. The thoracic disease usually is asymptomatic unless there is very large tumors or else there is liver involvement as well. 95% will be in the lung or endobronchial tree within the chest. 2% will be in the esophagus in the chest. 2% in the mediastinum, and less than 1% actual primary tumors in the intrapericardial or other structures of the heart. So we're really talking about primarily the endobronchial and the lung tissue itself. You have a very small number elsewhere. Carcinoid, again, is a very small number of the total thoracic chest, so you don't hear much about it. And once again, you say you may have a lung cancer, and everybody immediately jumps to Aunt Minnie and Uncle Louie, who have had cancer and want to tell you about those. This is completely different, and so you just have to politely say, that's nice, thank you for sharing your story. Mine is a little different, and it's just different, and so am I. And, or you can say I'm unique, or however you want to voice it. 85% will be the typical, and 15% will be the atypical. The atypical are the ones that are certainly a lot more worrisome and a lot more problematic. It may appear in all age groups. However, it seems to be peaking in the 45 to 55 age group, so it's kind of a bell-shaped curve. It's interesting that under the age of 50, it's more common in women. Over the age of 50, it's an even distribution, or slightly more to men. The atypical carcinoids are more frequent below the age of 50. Is this just because they are a more aggressive form and we're seeing it at an earlier age? It may be. We don't understand that, but it's just the anecdotal observations. The typical carcinoids will have the typical carcinoid tumors have a smoking history of only about 20 to 33%, whereas the atypical carcinoids do seem to have a much higher frequency. 60 to 80% of people with atypicals have a smoking history. So is smoking an accelerant? Is smoking something that causes a de-differentiation? Or what is it? You know, the same extrapolation goes on to the uranium workers and especially the plutonium workers. There was a very high incidence in plutonium workers of getting lung cancer, but it was unusual to see a plutonium worker who was a non-smoker that got the lung cancer. It was a plutonium worker who was a smoker that had a much higher rate. There's so many of these associations. We don't have answers. We're just looking at associations, trying to find the clues of where are we going. The anatomical location within the lung, 10% occur in the trachea or main stem bronchi. If you really think about the lung, compare it to a tree, kind of hanging upside down, but you've got a central stalk of that tree, the trunk, and that is the trachea and the main stem bronchi. And then you begin, the main stem bronchi are branching out into the branches, and you get the secondary branches. You've got 3 lobes on the right side, 2 lobes on the left side. The right lobe, the right lung is larger, it's 60% of our lung volume. The left lung is smaller, it's 40%. Well, of course, you've got the heart sitting in the left chest. There's less room for it. So you just begin to look at some of these things. And so if you get 75% of them occur within the lobar bronchi, 15% are peripheral lesions, but those are the ones that we're beginning to see more of than we used to, and it's probably because we've got better scanning. It's more common in the right lung. Well, the right lung is 60% versus 40%. You would expect to see, if it's even distribution, 60% right lung, 40% left. Yes, so does that differentiation mean much? No, that's just the frequency. The right middle lobe is the most frequent location. That one doesn't make sense. It's the smallest lobe, and why do we see it most frequent? And the right middle lobe doesn't have any special thing other than you have more lymph nodes right at the base. You tend to have some more infections in the middle lobe, but we really don't have any association to explain that. The nodal involvement with the typical carcinoid is fairly low, 10 to 15%, whereas nodal involvement with atypical is much higher, 35 to 50%. And that truly represents the aggressiveness of the tumor. The typical, more indolent, slower, very slow growing. It's also very slow to metastasize or spread to the nodes. So all of those things make sense. Of the people that present with carcinoid, 39% are asymptomatic. 25% will have non-productive cough. 27% will have a productive cough. Now you'll notice these numbers don't just all add up to 100 because there are people that present with multiple symptoms. Hemoptysis, or coughing up blood specks, about 30%. Dyspnea or wheezing, shortness of breath, wheezing, seen about 25%. Chest pain, 18%. But the lung really doesn't have much in the way of pain fibers. And so it's to be expected. You wouldn't expect them to have much in the way of chest pain. Usually when they have chest pain, it's because there's pleuritic involvement, because there's some involvement of the pleura. The pleura, if anybody's had pleurisy, you know there's a lot of pain with that, but that's not from the lung, that's from the chest wall and the surface of the chest wall. The true carcinoid type symptoms, sweating and flushing or diarrhea, seen in 10%. So a very low number are basically associated with the typical carcinoid type lesions. So as I mentioned, the true carcinoid lesions are primarily seen in very large tumors, greater than 5-6 centimeters, or liver metastases. We've really talked about the most commonly seen peptides, etc. We can skip over that. It's interesting that it's in typical or regular GI carcinoid, most of the cardiac lesions, as I alluded to, are on the right side. Because where does the blood come from the GI tract? It comes up through the vena cava, through the right side of the heart, hitting the right-sided valves, primarily the tricuspid valve and the pulmonic valve. The left-sided lesions are rare in GI carcinoid, but they may be seen occasionally in the lung because suddenly you think about it, as the blood leaves the lung, where does it do? It goes through the pulmonary veins, back to the left atrium, out to the mitral valve, into the aortic valve. So the pulmonary, you may see left-sided lesions. It's most unusual, but it can occur. Diagnosis has all been kind of gone over by the other people. Usually you get the CT scans, but really 75% of the lesions you may see something on an x-ray. Most of the time, even in the central bronchioles, you may not pick it up on the chest x-ray. Initially they get a CT scan and you go back and you say, in retrospect, aha, there has been a change, there is something. But certainly the CT scan has been the most key part as far as the initial diagnosis, then going on up through PET scans, occasional tried scans, and then all the various different types of weighing to get a biopsy. Certainly, as Dr. Kobatari mentioned, getting an endobronchial tumor, the patient may or may not have had any bleeding at all, but certainly, it's kind of like touching a sleeping snake. You go in there and they take a biopsy, a bite or a brush, and bleeding can and does typically occur. And it can be a frightening, significant bleeding that usually can be tamponaded, treated with topical epinephrine. But that's a hallmark of the biopsy of a carcinoid tumor, is to have bleeding. The treatment of choice, I was glad to see that other people agree, that the treatment of choice still for most carcinoid tumors is the complete surgical resection. So with that, we'll kind of go on a little bit into what we're talking about, the goal of complete excision, but yet sparing as much normal lung tissue as possible. So how can you get the carcinoid out without taking more lung than needed? Because lung is essential. Breathing is good. Breathing is essential. And if a person has normal lungs, you can take out a lobe or two lobes. You can even take out a whole lung. But each thing of lung you take out is more and more of a problem. And for those of us that live here at high altitude and function at higher altitudes, venturing into the mountain, this is even more critical. People at sea level can get along with a lot less lung, functional lung, than we can at this altitude. And if you happen to spend time in Vail, Aspen, Telluride, any of those places where you start getting 7, 10, 15, or 14,000 feet, it can be even very limiting or make life impossible. So our goal has always been complete resection of tumor, but limiting lung tissue loss. To mention, lymphadenectomy is required for adequate staging. It's not a total lymph node sweeping. And part of understanding that, if you think about it, you feel your neck. You don't feel lymph nodes. But yet if you get a cold suddenly or a sore throat, you've got all these big lymph nodes. And then that clears out, those lymph nodes goes away. We have thousands and thousands of nodes. It may be the little tiny things, but they act as the filter system of our body. If your filter system is picking up something, the lymph nodes enlarge. And so that's why I've mentioned a lymph node of greater than 2 centimeters, or a lymph node that usually takes about 2 centimeters of tumor to be positive on a PET scan anyway, is very worrisome. And you can always, you sweep and you basically get the big nodes, and you try and sweep all the nodes right at the base. But once again, going back to the tree, where are we finding those nodes? We're going to look at the nodes right at the base of that branch, in that lobe, and get where that tumor is. It's in that lobe. We're really going to look right at the base. That would, in essence, be level 1 nodes. Then we're going to look at the base of that big branch. There's 2 big branches coming down to the trunk. That's right at the hilum of the lung. You're going to look at that zone. And then you're going to go down and look at the roots. You're going to go up and down the mediastinum. You're going to get the subcarinals just beneath the carina where the trachea divides. You're going to go down to the inferior pulmonary ligament, especially on the lower lobe lesion. You're going to go up on the epibronchial, on the upper lobe lesions. You're going to go up on the paratracheals, because we're tracing up and down the roots of the trees, trying to see, has there been any evidence of spread? So you always get at least 3 and try to get 4 zones or 4 fields to get different spots, again, tracing out what is the normal progression of tumor. It isn't anything very magic. Surgery is really pretty simple, but it's very logical, and so you have to look at it that way. But I thought we could really get a good, at-home series on, sell some tapes on it. So as we talk about surgery, you also have to assess with pulmonary surgery, what is the functional capacity? So we're not only first looking at the patient, are they viable, or the individual having some problems? Do they have underlying emphysema? If so, how bad? So you look at pulmonary functions. We may look at even arterial blood gases to see, are they hypoxic? And if all else fails, a very simple thing, how far can you walk in 5 minutes? That tells you cardiovascular fitness. It also tells you pulmonary fitness. And if you can get 50 feet in 5 minutes, that's trouble versus can you in 5 minutes get a couple hundred feet or how far. So you don't have to have a lot of sophistication to see how far a person can walk in 5 minutes. Can they walk up and down one flight of stairs? You ask them. Well, if you get up one flight, you have to stop. Can you go up a second flight? Well, these are just keys that look at what is the pulmonary structure, what is the physiology of this. Then we start talking about the controversies of treatment. Come back to each one of these. Should we consider a thoracotomy or a VATS, video-assisted thoracotomy or thoracoscopic surgery? The difference is, should we take and make a 6 or 7 inch or 8 inch incision, whether it splits the muscle, spares the muscles, but basically make an incision, put a retractor between the ribs, crank the retractor so you get it big enough so you can get one hand into the chest and get your instrument in? Or should you be able to do this by VATS, which means make a 1/2 inch incision down low on the chest wall where you put a TV camera or a scope with a camera. You come up a little higher, make about a 3 inch incision, go a little higher posteriorly. You can go with a 1 or 2 inch incision where you can pass instruments through. So you never really have to spread the ribs. And can you get in there and use your instrumentation? And now we have a good stapler where we can put a stapler or a clamp right on the lung. It fires 2 triple rows of small titanium staples and cuts in between, and you can just go right through and take out a piece of lung, a section of lung, a whole lobe of a lung, or can you take out a pneumonectomy? Those things are possible, especially with the more peripheral lesions. When you get down to the more central lesions, where you're down around those big things called pulmonary arteries, pulmonary veins, the heart, etc., with the central lesion, usually you still need to go in with the thoracotomy. The difference is with a VATS, your recovery is about twice as fast, etc. We'll come back to that. And we'll talk about lobectomy versus segmentectomy. How much lung do we need to take? Lymphadenectomy we've talked about. Pneumonectomy we'll come to. Adjuvant treatment and neoadjuvant treatment. There are times when a person has a tumor and we say, can we decrease the size of that? Can we either ablate it? Can we, with chemo, with radiation, can we reduce it and therefore reduce the amount of lung tissue we need to take and yet get clear margins? Because the hallmark of taking it out is complete. That means you have to remove all of the tumor and have a margin of clear tissue, of normal tissue, not leaving tumor cells behind. And we can talk about endobronchial resections, which is one of the things that go to controversy. So again, I started to say on the VATS versus open. First, as VATS evolved over the last 20 years, the first studies were VATS, or a limited resection through a small, is it comparable? Can it be done and is it comparable? So you first came out with studies that are saying non-inferiority. Isn't that nice to be, you don't want to be inferior, but that's what it said, is it as good as? And then now we're looking back saying non-superiority, is it better than? So there's lots of debate in the literature about non-inferiority versus non-superiority, trying to determine what direction you can go. But certainly it has been proven, A, you can do this surgery by VATS with lung tumors, with lung, you can do it with the carcinoids. And is it better? Well, from a long-term follow-up, it probably isn't any better, but from a quality of life and from an experience of the patient, sometimes less is better if you bounce back and get out of the hospital in 3 to 5 days rather than 5 to 7, and you're back on your feet pretty much in normal at 6 weeks rather than 12 weeks. So to the patient, the superiority, inferiority is a whole lot different than the actual discussion in the literature about what are our results. But the bottom line is that 4 years and beyond, with sizable numbers now, we really see that the survival and disease-free state at this point in time is, with limited resections by VATS, is just as good, if not better, than by open thoracotomy. For the mid and peripheral lesions, for central lesions, we still need thoracotomy. Here we come about lobectomy versus segmentectomy. And I truly believe in lung cancer in general, and it goes to carcinoid as well. As surgeons, we're probably dealing with the neoplastic disease in the chest much to where the breast surgeons were 20 years ago, when everything used to be, or 30 years ago, everything used to be a full radical mastectomy, and now we're down to lumpectomies, lymphadenectomies, and appropriate other therapy. I am a believer that less is better oftentimes, that we can do a good segmentectomy or bisegmentectomy, taking out part of a lobe rather than taking a whole lobe. So long as the tumor is small, we're finding it early, especially in typical carcinoid. In atypical carcinoid, I would be more aggressive and do a lobectomy. But in typical carcinoid, I think less is better. But right now, I will have to tell you, part of it is my emotional belief of it. Do we have scientific fact yet? No. We're going to need to know that, and we'll know more about that probably in another 5-10 years. But it certainly is appearing that a more limited resection is reasonable in typical carcinoid. And part of this, especially at altitude, the less lung we take, the more lung the individual keeps, the better their quality of life. Then in dealing with trying to preserve lung, there are times when we're doing sleeve resections. You may have to go down, especially on a middle lobe, and sometimes on an upper lobe, where you take a lobe, but if you get margins around it, we have to take part of the bronchus and then sew the bronchus back together again. Sleeve resections do have more problems. There's a 7 to 10% difficulty at the anastomosis when you do a sleeve resection. So if you can avoid it, it's better. But if it means keeping a lobe and getting the tumor out with wide margins, you save 7 to 10% at the time of surgery, and the immediate perioperative time is reasonable. Long term, with a sleeve resection well done, as it heals well, we should be fine. As I mentioned, the large tumors and the central tumors still require a thoracotomy, and we basically have to be certain, can the patient withstand more of a resection. Lymphadenectomy, as I mentioned, we've kind of covered that. People are trying to extrapolate from other tumors into chest tumors, let alone carcinoid. The facts aren't known yet. We're still looking. Pneumonectomy. Pneumonectomy says removing an entire lung. Well, an entire lung, if it's the left side, it's 40%. If it's the right side, it's 60%. That's a major insult, and you have to have normal lung function to even withstand it in a normal heart. I always say that a person who has a pneumonectomy, you trade one disease, your disease is cancer, for another disease that's called a pneumonectomy. It's not done lightly, and it certainly has its own limitations and its own effect on lifestyle. So we try not to do pneumonectomies if at all possible. Yet there are times when we still need to. This is where neoadjuvant, reduction of tumor mass, etc. comes in, of can we downstage a person and to do a more limited resection. A very important factor. Adjuvant therapy we've talked about, and neoadjuvant therapy, can we do more to try and shrink tumors? And afterwards, it depends upon, do we need adjuvant? Have we got a complete resection out or not? Endobronchial lesions. This is one where we're really talking about the future. If we find a typical carcinoid and it's only in the bronchial tree, can we do a more limited resection? But the real key is it only in the bronchial lumen. As Dr. Kovatari's nice slide showing the iceberg effect. And there are too many times when we see a little blip on the inside and you look out on the outside and there is a great big tumor on the outside. We can't do that with an endobronchial unless it's palliative. But because we're seeing more people catching things earlier. If we find an endobronchial lesion, 5 years, 10 years down the line, can we have such things as nanoknife, other types of ablative therapy that we could actually shave off, remove more than the mucosa? It's not just the mucosa, we've got to get the submucosa, but not destroy the actual tracheal rings to be able to do a more limited resection. I think this is the future. We're peaking at it as technology, as better scanning shows, as better imaging shows, as better technology shows. We will evolve, but this is the state of it is now. When we talk about mediastinal and esophageal disease, it's such a small group, 1-2% group, and the same points apply. Resect whenever possible, and the question is, even in the esophagus, can you do a submucosal resection, or do you need to do an esophageal resection? The key point on mediastinum or esophageal is clear margins. It's such an unusual thing, although this past year I had one lady who presented with Flora-Cushing syndrome. She had a little ditzel in her pituitary, and they were kind of chasing around as a 1 or 2 millimeter pituitary lesion there, and we looked in the mediastinum, and there was a 4 centimeter nodule sitting in the center of the mediastinum. We went in and took it out, and it took her about 2 weeks to clear, but all of her elements from her Cushing's disease began to clear out, and she normalized, but it's been a long, slow process. So it's unusual, but it still can be there. And it was strictly nothing but a carcinoid tumor sitting in the mediastinum that had all the paraneoplastic syndrome that gave a full carcinoid syndrome. So those things do occur, but you have to look for them to find them. So in summation, 2016, the principle of complete resection, surgical resection, remains the best possible treatment. Always makes me feel good when the pulmonologist says it's a gold standard. Yes, a chance to cut's a chance to cure. But other forms of therapy with less tissue destruction are the goal, and managing for the long-term effect is the ultimate goal. Any questions?